It's my pleasure to introduce Dr. Shani Buggs for the next presentation. She is a postdoctoral fellow in violence prevention research at the University of California at Davis. She's also an affiliated research analyst with the Center for Gun Policy and Research at the Johns Hopkins Bloomberg School of Public Health. Dr. Buggs.
Thank you, Josh, and good morning, everyone. The group violence intervention and cure violence models are two of the most well-known strategies for reducing gun violence among individuals most at risk for violence. Both approaches are rooted in the concentration of violence theory, which suggests that a substantial proportion of violence in any given community is driven by a small number of people. Research in cities across the country, including Newark, New Orleans, Seattle, Oakland, and Chicago, has found that the majority of gun violence is committed by a single-digit percentage of those cities' populations. Research has also found that there is great overlap between those who commit violence and those who become victims of it, due to similar geography, social and peer networks, and risk behaviors. So by concentrating on those individuals who are at greatest risk for violence victimization or perpetration, communities can see potentially substantial reductions in gun violence. This conceptual model, highlighting the similarities between the group violence intervention and cure violence, was adapted from one created by Dr. Katerina Roman at Temple University. It shows that both strategies aim to identify those at greatest risk for violence, to interrupt conflicts before they escalate or continue a cycle of retaliation, and to engage community organizations and members in the strategies. Through these actions, the objective of steering individuals and groups away from violent situations can be achieved, which then leads to declines in gun violence and a shift in the acceptability of violence as a means to handle disputes and conflicts. However, these interventions accomplish these outcomes through two very different processes. The group violence intervention, or GVI for short, was developed in the 1990s by criminologist David Kennedy, and it has since been referred to as focused deterrence, pulling levers, the group violence reduction strategy, or ceasefire. The model relies on the threat of law enforcement intervention for those who do not heed warnings of severe consequences if gun violence continues. The strategy entails the formation of a cross-agency enforcement team, including local, police, city, state, and federal prosecutors, federal law enforcement agencies, and parole and probation departments. It utilizes data and intel from frontline police officers and detectives to identify key individuals within groups involved in violent activity. The enforcement team then develops a strategy to influence the behaviors of those individuals and groups by using all possible legal sanctions against them. Once the strategy has been determined, a call-in or personal notification meeting is held to directly communicate that the gun violence must stop and that there will be severe sanctions and enforcement actions if it does not. The message from law enforcement is accompanied by messages from community members who have been negatively impacted by gun violence and who implore the individuals to cease the harmful activity. And the model includes a concrete offer of services from local agencies and community-based organizations to support behavior and lifestyle changes. If a shooting does occur following a call-in or notification meeting, and the police determine that it involved a member of one of the groups represented in the meeting, then the enforcement team delivers on its promise of harsh consequences to the entire group. Since its formal development, the focused deterrence model has been applied to various types of crime concerns, including illicit drug selling, and has been evaluated over 24 times. A 2018 systematic review of focused deterrence interventions found that nearly 80% of the evaluations showed that the interventions significantly reduced crime, and that the greatest impact was found when the approach focused specifically on curbing violence. For example, in Lowell, Massachusetts, the intervention was associated with a 44% reduction in gun assaults, with no evidence that the violence was displaced to other areas. In New Orleans, the intervention was associated with a 17% reduction in total firearm homicides and an over 30% reduction in homicides among those whose groups were represented in the call-in meetings. And Indianapolis saw a 40% reduction in homicides following the intervention's implementation. However, there are several points to note regarding the GVI. First, the model has evolved over the past 20-plus years since it was first introduced, and different jurisdictions have interpreted the significance and application of the components of the strategy differently. We also know that although many replications of the model have been independently evaluated, other cities that have not undergone evaluation have opted to implement some or all of the strategies. So we don't know the full scope of the model's effectiveness. The evaluations that have been done have only examined the intervention's impact for around 1 to 2 years, so the model's ability to reduce violence over longer time periods is unclear. Additionally, several evaluation studies have found that threats to model fidelity can occur at several stages of implementation, which can undermine the success of the intervention in a given community. And importantly, because the GVI is most impactful when its focus is on the specific behavior of gun violence perpetration rather than criminal behavior or group identity more broadly, it requires a fundamental shift in policing strategy and in engagement with communities that are often already distrustful of law enforcement. The Cure Violence model is premised on a much different approach to violence deterrence. Originally known as Ceasefire Chicago, where it was first applied, the model is based on evidence that violent behavior, like infectious diseases, exhibits properties of contagion, including clustering, transmission, and spread effects. The model entails 3 specific components: interrupting violence transmission by mediating conflicts and limiting the likelihood of retaliation, identifying those at greatest risk for violence involvement and reducing their risk through behavior change and linkage to needed services, and changing community norms around violence through community mobilization and anti-violence messaging. The intervention employs street outreach workers to develop relationships with the individuals at high risk for violence. The outreach workers often themselves have had criminal or violent histories and are well known in the communities in which they work. They have also undergone personal transformations and desire to steer the individuals with whom they work away from violence. Being previously engaged in or familiar with the very behaviors and activities they hope to change increases the likelihood that the outreach workers will be seen by their intended clients as credible messengers and potentially trustworthy resources. The staff then serve as role models who can exhibit pro-social behavior while helping to link individuals and their families to critical supports and services. Through those relationships and supports, program participants and those around them will ideally choose positive paths of development and conflict resolution. The model also employs special outreach workers who operate primarily as violence interrupters, working to identify, mediate, and de-escalate potentially dangerous conflicts that could lead to shootings. The violence interrupters play an essential part in teaching nonviolent dispute resolution and minimizing the spread of violence by interrupting retaliation following a violent incident. Because of the need to build genuine and trusted relationships with those at greatest risk for violence in order to mediate conflicts and effectively help provide support, it is critically important that the outreach workers and violence interrupters maintain a clear distinction from law enforcement. Though the employment of street outreach workers to connect with and help redirect individuals involved in violent activity has existed for decades, the Cure Violence model was developed and codified in the 1990s by epidemiologist Gary Slutkin. The model has since been replicated in dozens of cities in the US and around the world with numerous independent evaluations. Those evaluations have yielded mixed program results. For instance, in Chicago, The program was associated with reductions in non-fatal shootings in some, but not all, of the communities where it was implemented, and program effects on group-involved homicides and retaliatory shootings varied across sites. In Philadelphia, the program was associated with a 30% reduction in non-fatal shootings 2 years after it was implemented, while in Baltimore, the program was associated with reductions in homicides or non-fatal shootings, but not both, in 3 of the 4 communities where it was implemented, and more recent evaluations show that its effects have attenuated over time. Several evaluations have also examined Cure Violence's influence on attitude changes about the acceptance of violence to handle conflicts. They found that the program was associated with significant improvements in attitudes towards violence and with increased confidence in relying on police to intervene when violence occurs. However, like the GVI, several Cure Violence replication sites have encountered major implementation challenges, from hiring the right outreach workers to adequately supporting those who work in the program, to providing program clients with sufficient and appropriate service linkages. And there have been some concerns about the program's ability to sustain reductions in gun violence over time, due in part to the evolution of the nature of gun violence over time, and who may be seen in a community as credible messengers with influence to intervene in conflicts. In interviews with street outreach workers and violence interruption workers, researchers have found that some types of grievances, such as those involving retaliation for the murder of a family member or friend, are more difficult to mediate than others. There can also be problematic tensions between program workers and law enforcement, who can sometimes view the alternative strategy as counterproductive to their own violence reduction efforts. We have learned important lessons from the implementation and evaluations of the GVI and Cure Violence models. Some cities have used those lessons, along with requests from communities most impacted by gun violence, to reimagine public safety and combine the approaches, while also incorporating essential elements such as case management, mentorship, and healing through cognitive behavioral therapy. New York, Oakland, and Los Angeles have each achieved impressive citywide reductions in gun violence by focusing less on any particular model and authentically engaging with communities, allowing for collaborative strategic planning and meaningful feedback loops. They seek to meet individuals where they are on their change readiness and personal goals, and they provide wraparound services to address program participants' needs. They have integrated elements of life coaching, restorative justice, and community empowerment into program offerings. They prioritize approaches that encourage positive police-community engagement. And most importantly, they have allocated substantial and sustained resources for gun violence prevention programs, their participants, and the staff doing the work. Knowing what we know, policymakers at every level of government, mayors, city managers, city council members, state governors and legislators, congresspeople, and federal agency heads should recognize that public safety starts before and extends far beyond police and emergency services. Local officials should authentically engage residents in the development of public safety plans for their communities so that the residents can help drive the changes they want to see. Local and state lawmakers should invest in strategies that concentrate on those at greatest risk for violence, that employ community members in both messaging and action, that provide bona fide support to individuals and families by connecting them to the services they need to aid lifestyle change, and that foster trust building and reconciliation between police and communities. And finally, Congress should allocate long-term funding and devote resources to spur innovation in gun violence reduction approaches, especially those that are community-driven and community-approved, and to effectively evaluate promising interventions for their impact and scalability. Thank you.